Live from Springvale, it's cardiovascular. This is part 4. This is actually kind of a potpourri. There's a bunch of stuff that didn't fit anywhere else that I've kind of fit in here. I'm going to kind of fly through some of the lipids slides just because I do think that you can spend almost too much time focusing on these just because there's so many different sets of guidelines. So I'm going to kind of hit the concepts that were involved in ATP3. We know that there's newer guidelines, competing guidelines, but just to throw these out there. So hypertension in women, how are women different than men? Women have less cardiovascular disease, but if you actually look at as women age, they get things about 10 years later, but overall, they get roughly the same amount of cardiovascular disease. So that's why we do the wear red thing every year, just to remind ourselves that women also do get cardiovascular disease. Oral contraceptives are a fascinating thing. We talk about how they increase blood pressure. Therefore, whenever you have a woman who is on oral contraceptives, you want to be checking their blood pressure on a regular basis. Sometimes we even start them on medication therapies just so that they can continue their oral contraceptives with less risk. Other options exist. They can always have a Mirena place, those kinds of things if they do have high blood pressure, and it may come down, but it may not too. HRT, hormone replacement therapy, theoretically doesn't raise blood pressure. Seems to use a little bit less estrogen. Maybe that's why. It's also possible that we've just never caught it. So if a woman gets hypertension, she can consider other forms of contraception as noted. On the other hand, we can also just treat her. Pregnant women are definitely a entity on their own. Some of you may be in practices that do manage pregnant women. I'm not, of course, but the medications that we use include methyldopa, beta blockers, and vasodilators, like apresoline, kind of the old-fashioned stuff. NB, old-fashioned abbreviation, meaning note bene, note well. ACE inhibitors and ARBs, not used in pregnancy. Never, ever, ever. So children and hypertension. So in kids, hypertension is actually defined as a blood pressure greater than the 95th percentile. Therefore, the number is actually going to vary depending on the age of the child, just because the normal blood pressures vary by age. Lifestyle interventions, of course, are the first thing to do. May or may not be effective. Drug therapy might be useful. I think that looking for secondary hypertension is always something to think about in younger people, and pretty low threshold for possibly getting a pediatric nephrologist or maybe a pediatric cardiologist involved to help you manage those kinds of things. Most of the drug choices are pretty similar. Obviously, dosing is going to be lower because they are smaller. People with high blood pressure, children, not really a reason to restrict their physical activity. They don't usually stroke out, but we do want to kind of catch them and treat them if possible. This is why we do blood pressures after about age 2 for well-child checks. Hypertensive urgencies and emergencies. If you've got somebody that has a really high blood pressure, the key issue is whether they have any sort of target organ damage. Do they have evidence of encephalopathy, a heart attack, angina, pulmonary edema, stroke, head trauma? Something that really shows that there is some sort of negative outcome associated with this blood pressure. If people do not have target organ damage, in general, you do not need to hospitalize them. Probably don't even need to do intravenous medications. Most people, unless they have some sort of a risk factor, can tolerate having an elevated blood pressure for a period of time. Patients will panic. People will be at a lab and the lab techs will take their blood pressure. The lab techs might panic and send them to the emergency room. Almost never do patients need to go to an emergency room for high blood pressure. That being said, if you have somebody that has a markedly elevated blood pressure, you want to get them on treatment essentially immediately. And if it's high enough, you're going to use double drug therapy. So, start them on a beta blocker diuretic combination, start them on an ACE inhibitor diuretic combination, start them on double drug therapy. We don't want to get their blood pressure down precipitously. We learned that the short-acting calcium channel blockers brought blood pressure down great, but caused strokes and other problems. So we don't really want to do that. We want them to glide in a little bit more gradually, but we don't want it to continue to be elevated. So the DiPiro book says anything over 180 over 120 is something you really have to address. JNC7 actually said 230 over 120. Again, those are numbers that some people will send them to the emergency room. It's not wrong, but generally, if you can get them on double drug therapy, their blood pressure will come down fairly quickly. The other thing, of course, is that if they know that you're worried about their blood pressure, obviously their blood pressure goes higher. So target organ damage is defined. We talked about some of the issues. But if you really do have left ventricular hypertrophy, if you have angina, if you've got heart failure, if you've got evidence of stroke, if you've got evidence of acute or chronic kidney issues, peripheral artery disease, I think is really hard to diagnose and correlate to hypertension, so I'm not sure I would pay attention to that one. Retinopathy, most of us really do not have skills enough that we're going to be able to pick up retinopathy on fundoscopic exams, so we can talk about that in class, but the data that I've seen shows that half of internists and 2/3 of family doctors aren't competent with fundoscopic exams, so I don't think we need to feel bad that most of us are not that terribly good at it. So other things that you can think of when choosing antihypertensive medications, the thiazides are probably underused, and we've talked a little bit about the chlorothalidone hydrochlorothiazide controversy. Chlorothalidone has better data in 1 or 2 studies, but thiazide diuretics, hydrochlorothiazide especially, are cheap, cheap, cheap. So many of us still continue to use the thiazides. They do seem to slow demineralization. So if you have somebody that has osteoporosis, it may be undesirable to get them on a thiazide diuretic. Beta blockers are useful if you've got, somebody that has AFib for rate control. Migraine, it's a good prophylaxis for migraine. If somebody has high thyroid function, again, you're not going to see that very often unless you have somebody come in with, hypertension associated with thyroid issues. Essential tremor, 2 major types of tremor, essential tremor and a Parkinsonian type tremor. Parkinsonian type tremor is a resting tremor. Essential tremor is a intention tremor. They go to do something and their tremor gets worse. Usually it's just familial. There's not a whole lot you can do about it except beta blockers, and beta blockers will usually improve those symptoms. And obviously if somebody has perioperative hypertension, beta blockers are a good choice. They work pretty quickly, and this is why if you have somebody that needs to bring their blood pressure down more quickly, lots of times we'll choose beta blockers. Calcium channel blockers are great for Raynaud's. If you have somebody that has that sort of red, white, and blue, their hands get cold. Obviously, Raynaud's can be caused by cancers and other, primary causes, but most people with Raynaud's, it is just idiopathic, and you do just want to manage it. Alpha blockers, back to calcium channel blockers. If you have somebody with AFib or something like that, you can use them for rate control as well. Alpha blockers obviously relax the sphincter in the prostate area and are therefore good in prostatism. Prostatism is just a term that means getting up at night to pee, difficulty starting your stream, decreased force of your stream, all the things that you usually see in benign prostatic hyperplasia. So what's the goal of therapy? Well, different guidelines say different things. So JNC8 says if you're over 60, you can be 150 over 90. The 2017 guidelines say no, you really need to be 140. So read the guidelines, decide what you yourself are going to follow and observe, get a sense of what the other people in your practice are doing, and then set those as your goals. Also communicate those goals to the patient very clearly. And so you really do want to try to achieve your systolic blood pressure goals, especially as people get older. Again, you may not get it exact, but within 4 to 6 points, because it will decrease the risk of heart attack and stroke. So people need to keep coming back. This is one of the things that people find hard, is you may need to bring them back every 3 months, every 4 months, really to try to adjust their medications. Obviously, if somebody has stage 2 hypertension, you may bring them back once a month or maybe even more frequently to try to get their blood pressure down, just because obviously you're starting at a higher blood pressure. And you may, in fact, have to start with double drug therapy right off. Check their potassium and their creatinine, especially if you start an ACE inhibitor or an ARB. Check those about 4 to 6 weeks after initiating treatment, and then at least once a year after that. After the blood pressure is at goal, guidelines talk about follow-up visits in 3 to 6 months. If I have somebody that's been on hypertension treatment for years and is stable, I will sometimes just see them once a year just to try to keep their cost and inconveniences down. Obviously, if you've got somebody that has heart failure, diabetes, stroke, anything else, you're going to, see them more often. So what do you do with that patient that you just can't get them to goal? They have resistant hypertension. Well, you want to make sure they're doing their blood pressure correctly. Make sure that they don't have an undersized cuff, because an undersized cuff will give you an artifactual elevated blood pressure. Make sure that their cuff is right. Have them bring their cuff in, compare it to the cuff in the office. Sodium intake, especially in somebody that you can't seem to achieve, restricting sodium, I think, is definitely worth a try. I think we've talked about the fact that only about 1/3 of patients are salt sensitive. The other thing is there's no real data that suggests that if you restrict salt, it decreases, endpoint outcomes, such as stroke or heart attack. But it will help you get to goal for blood pressure if you restrict their sodium intake. Make sure you've got these people on diuretic therapy. One of the challenges with that is that if you've got somebody that's, say, a long haul trucker and they don't want to have to stop to pee, they're going to be resistant. Most people that go on diuretic therapy, after a few weeks of diuretic therapy, their body kind of changes the set point, and they don't really have to urinate that much more often. So, if you explain this to them, sometimes they are willing to initiate diuretic therapy. Make sure your dose of medication is adequate. One of the things that people do is keep somebody on 10 milligrams of lisinopril and then keep saying, well, try to exercise more, try to, do the behavioral things. If you're not getting them to goal, you have to increase their dosing. Make sure they're not taking a lot of NSAIDs. This is yet another concern for a lot of NSAIDs. Make sure that they aren't taking any, either over-the-counter or illicit drugs that are kind of sympathomimetic, such as pseudoephedrine, or, there's certain Chinese herbs that are actually pretty stimulating as well. Review to see if there aren't oral contraceptives, etc. Make sure they're not drinking excess alcohol. A lot of people don't even necessarily ask it in their history, but it really is something that you do need to be very aware of. I had always learned when I was taking care of patients in detox years ago that you should double the amount of alcohol intake that they say they have. Not sure that you absolutely have to do that, but I think a healthy bit of cynicism is appropriate in regards to alcohol intake. The other thing is possible secondary hypertension. You may learn the appropriate workup for that with renin levels and aldosterone levels and those kinds of things. On the other hand, if we have nephrology readily available, which I actually do, I very rarely do a secondary hypertension workup. If I can't get somebody to goal with 4 drugs, I send them to nephrology. So that's my threshold. Different people have different thresholds. Some people, we'll send them earlier than that, but I usually start an ACE inhibitor. If the ACE inhibitor doesn't work, very often I'll add a little diuretic, add a little hydrochlorothiazide to it. If that doesn't work, I usually add amlodipine. If that doesn't work, I sometimes send them to nephrology. Sometimes I'll put them on something like clonidine in the meantime, just so their blood pressure isn't crazy high, but that's not a great medicine for the long term. So public health approaches, again, we've talked about in class the fact that I'm a little cynical about educational approaches just because I think that the majority of people know what they're supposed to be doing. They just don't do it. I think that a psychiatrist that I heard give a talk a few years ago made a statement that people change when the pain of changing is less than the pain of staying the same. So it really isn't just, oh, you need to change this, and then they say, oh, I didn't know that, and they change things. They really have to figure out in their life, what's causing them pleasure, what's causing them discomfort. A lot of people, salt and calories and those kinds of things are sort of a self-medication for them. So it really does relate to those people that are seeing a psych provider. It's really helpful if the psych provider can help them work on their behavioral issues and look at their blood pressure and other issues as well. So, but we may be able to get morbidity and mortality down using public health approaches. It's an attractive opportunity, but sadly, the potential has not really been realized that well. So, lipid therapies. When do you start lipid therapies? Well, different guidelines suggest different things. So ATP3, the last update was 2004. So we'll fly through these just so you're familiar with them, but obviously there are newer guidelines. The ACC-AHA guidelines were published in 2013, and there's major changes there, right? And we'll talk about those. So, but risk factors, all the usual stuff, don't eat a diet that really creates some plaque. Unfortunately, we now know that high carbs is probably more of an issue as far as weight than fatty foods, but polyunsaturated fats are substantially better than saturated fats. So, olive oil, those kinds of things. Other things we're looking at, we really don't know what else to look at. These have been being looked at for 8 or 10 years now. Breaking down the lipoproteins, looking at the type of HDL, looking at the type of LDL. A lot of work going on there. None of it really seems to be ready for prime time for things that we're really looking at. Some hospitals are actually giving you a lipoprotein A, which does seem to increase the risk of cardiovascular disease. The problem is that there really isn't a whole lot of data on anything that'll alter it. So all the other stuff is pretty self-explanatory. Obviously, cigarette smoking is bad. And this is why I say to patients, you really shouldn't smoke. And they're like, yeah, I know I shouldn't smoke. And then now we do actually have some things we can do to help them. The Chantix is actually it's a parasympathetic drug, which can help them stop smoking. It decreases the urge. One of the interesting side effects of one of the mental health meds, Wellbutrin or bupropion, also does seem to decrease urge. These are nice features because you don't have to worry about, too much nicotine or anything like you would with a patch. So obviously, if somebody's got high blood pressure or really low HDL, you're going to make sure that you try to get them to goal. Premature heart disease is a risk factor. Again, I don't think it makes a huge difference for me, but if I have somebody that's sort of borderline, I've calculated a risk and it's 7.1 or 7.2. If they have a really strong family history of cardiovascular disease, I'll try to convince them to start on a statin. HDL above 60 is considered a negative risk factor. There's some things that will raise it. Patients that are on tamoxifen will often have 90 or 100, sometimes even higher. Some people seem to have sort of a naturally high HDL. People with multiple risk factors, make sure you do that 10-year risk assessment. There's a couple of different ways to do it. I've posted both the regular cardiovascular risk calculator and the enhanced calculator on Blackboard. For people with low risk factors, some people don't do the risk assessment. I do it for everybody. And the old way was the 10-year risk being less than 10%. ACC-AHA really starts treatment at 7.5%. Diabetes is basically the equivalent of having had a heart attack as far as risk. We usually think of this as secondary prevention rather than primary prevention. People with coronary heart disease obviously go on statins, and usually a high intensity statin. So basically, again, if you've got high risk, 20%, you want to make sure you go with a high intensity statin, control their blood pressure, all the usual suspects. Obviously, if you've got somebody that has an abdominal aortic aneurysm, you're going to want to monitor it with either ultrasound or CT, depending on where it is. If it's easily accessible, ultrasound may be enough. If somebody has symptomatic carotid artery disease, you can decide whether or not to do routine carotid Dopplers. I'm not actually a huge fan of those, other than as an indicator of how much atherosclerosis there is in the body. I think it's probably a good thing to tell us that. But again, we've already talked about diabetes as a risk factor. And so what's your goal? So if somebody's had cardiovascular disease, ATP3 said 100 was your goal, we now say that 70 is your goal. For diabetes, most people use 100 as their goal. If you've got someone that doesn't really have any risk factors, we may be able to tolerate 130 or so. At that point, I always do a 10-year risk. Some of these people, if they're 42, they have a LDL of 135, they may actually calculate to be down in the 3 or 4% risk. That's still substantial, I think, for somebody in their early 40s, and I will often offer them a statin, but the guidelines would not necessarily suggest that that's necessary. So these were the old numbers. Obviously, anything above 190 requires immediate statin therapy. I don't think that there's any value to doing lifestyle interventions. The data that I've seen seems to suggest you'll get about 10% decrease in your LDL and in your total cholesterol from lifestyle. Obviously, if you're at 190, that's still going to leave you way higher than you want to be. And again, the HDL, anything under 40 is low for a man. Anything under 50 is really considered low for a woman. And total cholesterol, these are the old numbers. Basically, we want everything to be below 200. So what else can you do? Think about whether or not there's any inflammation or irritation of that intimal lining. And so we want to prevent LDL from depositing in that intima. If you've got really high, it's likely to deposit on anybody. Other people will have LDL deposit at even lower levels, and these are people that seem to have a lot of inflammation in their body. People that are smokers, those kinds of things. And so, somebody's a non-smoker, they take an aspirin, which again is controversial, whether you should be taking aspirin as primary prevention. The data is not conclusive either way. The risk of GI bleed is not high, but it's maybe high enough that doing primary prevention like that is not necessarily advisable. And the other thing to remember is that any plaque formation, even if you have a decrease, let's say your diameter is 10 microns. If you have a decrease of 1 micron, it's basically going to be the equivalent of decrease by 4 microns, because it really is, because of the pi and the circumference and all that kind of stuff. It really is a substantial decrease in the amount of blood flow in those vessels. So even stable plaque lesions can decrease flow, and especially if they get to the point where, they've narrowed by, 30, 40, 50%. If you have high demand for oxygen, you're not going to be able to get that blood flow through as well as you should. So what kind of plaques are there? There's stable plaques and there's unstable plaques. So an unstable plaque is one that's likely to fall off. There's platelet-containing, white platelet-containing plaques, and then there's some that are red that are fibrin-containing. We think that maybe the white platelet-containing plaques are more common in unstable angina. Again, this is one of the reasons that we use platelet adhesion drugs like aspirin or Plavix. The fibrin ones maybe are a bit more common in MI. It's a theory. And basically, I don't think there's any real value to thinking about this pathophysiology unless you're really going to get into the research, just because we're going to treat all these people pretty much the same. So what else might contribute? Obviously, chemicals such as nicotine. Smoking is bad. Bacterial infection may actually damage the blood vessel lining. So if you've got somebody who has sort of a chronic infection, they're going to be a little more likely to have cardiovascular disease. Hypertension obviously stresses those vessels. Issues with breakdown of lipids, etc. And obviously we know that if you have high cholesterol, we know that you have higher risk of clot. Not everybody gets that. There's some people that have high cholesterol that don't have any tendency to clot. Other factors just seem to override that. But we do know that if we lower cholesterol, that mortality and morbidity benefit, and especially overall mortality does benefit with statins, maybe with niacin, but I don't really think so.